Hello, everyone. My name is Kay Gooch, and I'm Director of Community Programs here at ARC. I'd like to welcome you to today's webinar on neuropathy and amyloidosis. But before I introduce our speaker, I'd like to give you a brief overview on ARC. So for those of you who are new to our webinar series or to ARC as a whole, here's just a bit of background on who we are. ARC is a patient-founded, patient-driven organization dedicated to improving and extending the lives of those who are affected by amyloidosis. We have 4 focus areas, which you can see on this slide: improving the speed and accuracy of diagnosis, increasing our understanding of the disease to identify new treatments, accelerating approval and reimbursement of effective treatments, and certainly also enhancing the care and quality and life of patients and caregivers who are affected with this disease. So please feel free to reach out or look at our website, which is arci.org, if you'd like to learn more. And also on this slide, I'd like to just take a moment to thank our sponsors and donors for their generous support of our ARC Talks webinar series. We certainly couldn't do this work without your support, so thank you. And just a few little housekeeping details before we begin. Today's webinar is recorded, and it will be posted on our website within a few days, so if you'd like to see it again, certainly you'll be able to do that. And we also will put the slides in as well, and you'll be able to download those too. Also, submit your questions anytime via the question and answer box. And we have question and answer time at the end, so we'll try our best to answer them at the end. If you are having any trouble with the audio using your computer, you can also have the dial-in information for your phone, and that would be in your Zoom invitation. You will also receive a survey at the end of today's webinar. As soon as the webinar ends, you'll get a survey that will pop up. So please take a moment to fill that out. Your feedback is always very appreciated and helpful, and helps us plan for future webinars. Also, just wanted to remind you, because today's topic is on neuropathy, ARC does have a book on neuropathy and amyloidosis, which is available on our website. You can see the email address here. It's arci.org/neuropathy, or you can scan the QR code here. And if you have trouble with that, you can certainly contact us and we can mail you a copy. But just wanted to let you know that we do have that booklet available. So now I'd like to introduce today's presenter, who is Dr. Sami Khella. Dr. Khella is Professor of Clinical Neurology at the University of Pennsylvania and past Chief of the Department of Neurology at Penn Presbyterian Medical Center, the University of Pennsylvania in Philadelphia. He graduated from the University of Pennsylvania School of Medicine. He did his residency in neurology and a fellowship in neuromuscular diseases at the hospital of the University of Pennsylvania. He has done clinical research on neuromuscular disorders and is the author and co-author of many papers on peripheral neuropathy and amyloidosis, among others. He is also co-founder of the Penn Amyloidosis Center, which is one of the largest centers in the nation treating patients with amyloidosis. This program provides not only clinical care, but also participates in cutting-edge research and clinical trials. So now I would like to go ahead. I'm going to stop sharing and bring up Dr. Khella and let him get started with his presentation. So Dr. Khella, welcome.
Thank you, Kay. This is wonderful. And I want to thank you and the team at ARC for inviting me to give this talk. ARC has been a wonderful companion and cooperating organization in the care and the research of patients with amyloidosis. And I'm really grateful for all that you and your team do. So today I would like to talk about peripheral neuropathy in amyloidosis. And these are my disclosures. And I also disclose that I'm a painter, and I take selfies and I take liberties. So there's poetic license on the left, and this is what I look like when I'm dealing with the insurance companies on the right, trying to get pre-authorizations. So amyloidosis was first discovered by the man on the right here, Rudolf Virchow. This is a picture of him in 1902. Virchow thought that what he found, the staining with the Congo red stain, was the amyloid was a starch, but it really turns out to be a protein. And while we think that this protein that I'll talk about more later on throughout the whole talk is what is causing the disease amyloidosis, we really don't know a lot uh, about the biology of this illness. And one of the features of this very busy slide is you can see this is what it looks like, the arrows in the middle of your screen, what amyloid looks like on the Congo red stain. And then when you put it under the polarizing microscope right here, you can see that in the black arrow and then in the yellow arrow, the deposits look what we call apple green birefringent. Here it looks more reddish yellow. And then when you do a special stain called an immunohistochemistry, you see that in the bottom middle panel is that little dot. That's the amyloid on the histochemistry. And you wonder to yourself, how could a little dot like that cause all the damage that it does to the tissues? So there's more to the biology of this illness than we really understand. So amyloid, the word amyloid means a misfolded protein and not a starch. And there are many different kinds listed here of proteins that become misfolded and become what we call amyloidogenic. The most common is AL, or light chain amyloidosis. And then the one we're going to talk about today is ATTR, is amyloid transthyretin. And you can see here, this is data from the Mayo Clinic. And you can see that if you look at by age, it affects older folks on average. So on average, they're in their 70s, give or take, 8 years or so. And it affects men more than women primarily. I'm going to stop my screen for a second because I think the timer is on, and I'm going to take that off. So bear with me 1 second while I do that. Otherwise, this thing is going to just keep scrolling right through. View, review. Well, I don't see it right offhand. This thing is a little funny, so my apologies. Okay. Anyway, I'll work through it. So amyloid, and it may jump back and forth, and you just have to forgive me for that. When you talk about amyloidosis, you'll hear people talking about familial amyloid polyneuropathy or familial amyloid cardiomyopathy. And unfortunately, many patients don't have a family history. So I like the term hereditary rather than, or variant hereditary amyloid TTR, or so hereditary amyloid polyneuropathy or hereditary amyloid cardiomyopathy, because you may not have a family history. Then there's the acquired form, which is the amyloid light chain that I talked about. This is a cancer-related amyloid. That's not what we're talking about today, and it's treated in a very different way, but it has to be distinguished from the hereditary form. And then there's amyloid, the wild type amyloid, where there's no change in the genetics of the patient, but they are still making TTR that is abnormal. So what is TTR? TTR is transthyretin. That's the name of the protein. And transthyretin is called that because it carries vitamin A or retinol. And it also carries thyroxine, which is hormone. So retinol is used for vision, and thyroxine is used in the thyroid. That's the name of the protein because it carries these two molecules and transports them throughout the body. Now, we do know that we ordinarily have a certain level of TTR protein in our body, but sometimes that level is very low, and we certainly aim to reduce it by treating hereditary TTR amyloidosis. And then we don't know what happens to people when they have a low level for a long time. There is a suggestion that it may be associated with some other diseases, but we don't really know. This is a new area in understanding this disease. So TTR is made mostly in the liver, as you can see here. 95% of it is made in the liver, but the liver is otherwise normal. So if you have TTR amyloidosis, you have a normal liver that's making an abnormal protein. And if you can think of a protein like a chain, like a chain that you wear around your neck, and the chain is made up of little beads, the TTR is like that, is like a chain, and the beads are the amino acids, and so the beads on the chain are in a particular sequence, and they have to be 1, 2, 3. That sequence has to be the way it normally are linked together. But when one of those chain links in the chain is the wrong one and in the wrong spot, that's why you get amyloidosis. Then the chain misfolds, or the protein misfolds, and then it becomes a toxic protein. So this is another way of looking at it. So the liver makes the right in the middle of your screen called the folded monomer. And normally that monomer likes to sit with 3 others to make a tetramer. And that's how the protein TTR circulates in the blood. It circulates as 4 monomers stuck together. And then you can see all the way on the left here, this is where thyroxine or retinol would bind to this protein and circulates around. When one of these chains, one of these links in the chain is the wrong one, and you have a monomer, or the protein is not folding properly, then this reaction shifts to the right, and you have a misfolded monomer. So the monomer then becomes this toxic protein that deposits in the tissue. You can see here, and it's these little fibers that we call amyloidosis. And then it destroys the nerve or the heart or whatever organ it's affecting. So this is basically the biology of what we're talking about, of the protein that we're talking about. Now, let me just show you an example of a person who I recently saw in my clinic. And this woman is 74. She's young relative to my age. And so she started out in 2021 with cold feet. And her feet then became numb and tingly from the knees to the toes. She had been extremely active. For 30 years, she was walking several miles a day, very active, doing all kinds of things. And then in 2023, she started to have trouble walking. Her feet started to hurt. And then in 2024, she started to have trouble going up steps. And by 2025, a year later, or even less, she started to have trouble going up a curb. So she's developing some weakness. To give you an example, in October of 2024, she was using a cane, and then that progressed to in 2025 to having trouble standing without help, had bilateral foot drop, was also having a lot of fatigue, was also having diarrhea, alternating with constipation, and she would get lightheaded when she stood up because of low blood pressure. Now, this is a little busy slide, but it gives you an example of her examination and the worsening weakness that she's developed. And you can see that she was seen by 2 different neurologists in November of 2024. And 4 means that 5 means normal, and 4 is a little bit weak. So they thought that her arm abduction or a lifting of the elbow like that was a little bit weak. Lifting of the hip was a little bit weak. It was 4. And bringing her ankle up was very weak, 2. So 5 is normal, 0, you can't move. So 2, you're really pretty weak. And then, so she was seen in November, and then she was seen again in April by one of these neurologists. And he thought that she was getting a little bit weaker still, but not very weak, except that now her toe extensor hallucis, her toes were getting weak. And he noted that. But when I saw her in July, so about 11 months later, I thought that her arms were pretty strong, but now look at her hips are starting to get weak. Her ankles are really very weak. And now her toes are completely paralyzed. And this is the kind of weakness and the progression, the rapid progression of this weakness in people with amyloid. You know, over a couple of years, they go from being strong to being really pretty weak. And usually it's in what we call the distal part of the limb, or the part that's farthest away from the body. And that's the weakness that develops. Now, she had some data, and I'm going to just share briefly some of the data, not so much for the numbers, but just to show you like what kind of testing people should have done. When somebody has a progressive neuropathy, we do a genetic test, and somebody did a genetic test on her, and she had this variant, this phenyl 84 leucine variant. So this is not the most common variant of hereditary amyloidosis, but that's what this lady had. She had a fat aspirate and a skin biopsy that didn't show the Congo red staining that I showed you at the beginning of this talk. She did have a cardiac evaluation for other reasons, not because of this. And then when I saw her, I did another cardiac evaluation, and I saw that one of her cardiac laboratory studies was very abnormal. Her so-called NT-proBNP was very high when I saw her. In 2023, a cardiologist had seen her, and her troponin, another heart enzyme test, was normal. But when I saw her, it had really gone up significantly, and it was now really quite abnormal. She had a cardiac echo, which is a way of looking at the heart. So it's very important in people with amyloidosis that their heart be examined. And again, the IVSD, that means the septum or the wall between the two chambers of the heart, was actually pretty thick. It was 1.2, and top normal was 0.9. She had one more thing that we checked for, which is we talked about amyloid light chain in the beginning of the talk. And so this is the kappa and lambda light chains. That's what we check for making sure the patient doesn't have a malignancy rather than a hereditary amyloidosis. And then a PYP scan, which is a pyrophosphate scan. And that's a scan for amyloid. And I'm going to talk about that in a second. So this is the kind of data that we evaluate a patient with when we have a suspected amyloid patient. I do want to show you the different kinds of variants. So Our Lady's in the one in the middle. She's the F64L. In the United States, the most common are the variants on the right, V122I. So this is a variant that affects primarily African Americans. And the T60 variant, those are the most common type. This is so-called Irish mutation. And these usually present as a heart problem, a cardiomyopathy, but they can also cause a peripheral neuropathy. The V30M is all the way to the left, and then at 1 o'clock on your screen. This is the one variant that's most common throughout the world. In the United States, so it affects people in Portugal, people in Sweden, as I'm going to show you in a minute. But it can cause either a pure neuropathy or a combination of a neuropathy or heart failure. And then cardiac amyloid wild type, you can see all the way on the right in the bottom of your screen. And that's mostly a disease of older men, and it causes a heart problem. So when we think about amyloidosis, we think about especially hereditary amyloidosis. You're born with this, and you go for a long time with having no symptoms, but there is an abnormality in the protein formation. So those proteins are depositing in the different tissues, and then people develop either a heart problem or a nerve problem. And unfortunately, and I'm happy to report that now that we have treatment, death is not really sort of part of the picture of this. So that's the really good news about this, is that I think people are living a lot longer with this disease than they had been prior to the modern era that we're in now. And so is where the different variants are. V122I is the most common, as I said, in the United States. T60 is a common variant in the eastern part of the United States, because that's where a lot of Irish people live, or people of Irish and English descent. And then the V30M is the most common in Brazil, Europe, Sweden, and Japan, all the way on the right. The isoleucine variant is common in Italy. We looked at the data that we had, 22,800 and some patients were tested. And unlike wild type amyloidosis, which affects primarily older men, unlike the malignancy associated with amyloid, which affects more men than women, the hereditary form affects men and women equally. So just a word about the V122I patients. So this is, as I said, the most common variant in the United States, but it's not the variant that's been most commonly included in the clinical trials. Now, if it turns out that about 3.2% or 4%, somewhere in there, of black people in the United States have this variant, and they're not sick with anything. And so it turns out that having the gene doesn't necessarily mean you have the disease. And you have to be careful about that, especially in somebody who's African American. And it used to be thought that this genetic variant only causes a heart problem, a cardiomyopathy, but it also turns out causes a peripheral neuropathy, as we saw here at the University of Pennsylvania. We looked at our patients. We found 82 patients who had the V142. This is another way of naming this disease, V142 or V122I. The V142 refers to the protein. The other refers to the DNA, but it doesn't matter. It's the same thing. And we found that about 40% of our patients had a peripheral neuropathy, but really you can only ascribe 13% to have the neuropathy thought to be due to the amyloid itself. The 27% difference is probably from other causes besides the amyloid. So you can have a patient who has the gene, the amyloid gene, but you don't feel that they have the amyloid neuropathy. And so you have to treat the neuropathy because of its cause, based on its cause. I'm going to skip this slide. So what is a neuropathy? And before I get to the red flag symptoms, a neuropathy is a problem where people will develop pins and needles in their feet. I showed you the lady in the case presentation with weakness, and the weakness is very often in the feet and legs, but it can also affect the arms. They often will describe trouble walking, and because like they feel like they're walking on sand, or that they are walking on hot coals, and they have a pins and needles feeling, in addition to the weakness. And that's what a neuropathy is. So I think about amyloid in a patient who has a neuropathy when I hear that they have heart failure, especially heart failure with what we call preserved ejection fraction, which means that the heart is putting out the normal amount of blood, but it is still failing. And carpal tunnel is another feature of this neuropathy. And a lot of people, and I'm going to show you a little bit of that later, a lot of people will have carpal tunnel years, up to 7 years before they actually develop amyloidosis. So if you have a history of bilateral carpal tunnel, you need to think about amyloid if that patient then develops other symptoms of a neuropathy. Now, autonomic symptoms means lightheadedness, like our patient showed, and diarrhea. Those are the symptoms of dysautonomia. Other symptoms of an autonomic neuropathy. So the autonomic nervous system is the nerves that control the blood pressure, that control the intestine. So that's why people get diarrhea and they get lightheaded because the blood pressure is too low. You can also have in men, especially young men, early erectile dysfunction because you need the autonomic nervous system to have normal erection. And then lastly, well, we need to worry about amyloid when we have a patient who has a neuropathy called CIDP, and that's one of the most commonly diagnosed neuropathies in the United States. And CIDP stands for chronic inflammatory demyelinating polyneuropathy. I'm sorry, it's a mouthful. That neuropathy is usually treated with IVIG, but it can also, and it usually responds to IVIG right away. When it doesn't, then you have to think to yourself, oh, maybe this patient doesn't have CIDP and they may well have amyloid because it has the same pattern of weakness and numbness and tingling as amyloid does, but it doesn't have the autonomic symptoms. So if you're diagnosed with CIDP and you're not getting better with IVIG or prednisone or some other medicine, then you have to think, well, maybe this is the wrong diagnosis and you should get another opinion. So I told you that about the PYP scan or the pyrophosphate scan, and this is a way of making the diagnosis. So just to back up a second and to tell you that amyloidosis, not only do you need to have the gene, the abnormal gene that is associated with amyloid, the disease, but you also have to show evidence that the disease is depositing, that the protein is depositing somewhere in the tissues causing disease. And so you can see, so you either take a biopsy, like I said, a fat aspirate or skin biopsy or something, nerve biopsy, or you could do a pyrophosphate scan. And you can see here that in this patient, this is the heart, and you can see that the heart takes up the pyrophosphate, which is a radioactive material. It's also taken up in the thyroid and the bladder. But anyway, and then you compare it to the contralateral side. And this PYP scan is the equivalent of doing a biopsy. Here's a biopsy from one of my patients on the left, and you can see the Congo red staining in the tissue here. And then under the polarizing microscope, you can see the color change, and you can see it also under the immunohistochemistry here. But then this is not enough to do a Congo red stain. You then have to do what's in the middle of the screen here, mass spectroscopy. Mass spectroscopy is a way of identifying what the protein is. So you have to make sure that you've got the right protein that is staining with the Congo red. So is it amyloid neuropathy? So a lot of patients will have the gene, as I said, and then will have a neuropathy, and you want to know, well, is this neuropathy from amyloidosis? Because we don't always like to do a nerve biopsy, because sometimes the nerve biopsy can cause a problem. It can be painful. It can miss the amyloid altogether. And in our patients here, we made the determination that you call it definite when you've got a nerve biopsy that stains with Congo red and you have the protein in the nerve. That's definite amyloid neuropathy. But we can call a probable attribution when you've got a patient with a neuropathy who doesn't have another explanation. And then you have possible attribution when you have one comorbidity, like diabetic neuropathy. So let me just talk about diabetes for a second. So diabetes, as you know, can cause a neuropathy that looks a lot like amyloid neuropathy. The difference is amyloid neuropathy, like I showed you in our patient, will progress over a couple of years. Diabetic neuropathy doesn't do that. Even with really bad diabetes, you don't get the profound weakness and the rapidly profound progression of the weakness that you do in amyloid. And so So in our patients, you can see that patients who had the V142I here, we had 34 of them, or 41%, had evidence of a neuropathy, but really 24% had definite, and 3% and 3 patients had probable. So that's a total of 27 patients, or about 30%. So about 30% of our patients had what we thought was really amyloid neuropathy, even though and 70% who had the V122I gene, we didn't think had amyloid neuropathy. So, I talked a little bit about CIDP, and some of you may be diagnosed with CIDP or had been diagnosed with CIDP, and I just want to show you the comparison. So as I said, amyloid causes distal, meaning far away from in the limb, the farthest away from the trunk of the body, and it's symmetric. So both limbs are affected. Same thing in CIDP. Proximal weakness, meaning the part closer to the body, it results in weakness, and that happens in amyloid. It also happens in CIDP. It doesn't really happen in diabetes. So the distal weakness can happen both in CIDP, diabetes, and amyloid, but not the proximal weakness. Amyloid has lightheadedness, early erectile dysfunction. You can get some of that in diabetes, but you don't get it in CIDP. People with amyloid often have weight loss, which is not a feature of CIDP. Especially they have weight loss, especially when they have diarrhea. Now, not everybody who has amyloid neuropathy will have diarrhea, and not everybody who has amyloid neuropathy also has weight loss. And amyloid neuropathy does not respond to IVIG, whereas CIDP does respond to IVIG very quickly. So carpal tunnel syndrome, just a word about that. This is from a Dutch study, a study from Denmark, showing that patients who eventually came down with a diagnosis of amyloidosis had carpal tunnel release on average 7 years prior to the diagnosis of amyloidosis. They also had another interesting thing, which is a biceps tendon rupture. So the biceps, as you know, is this muscle here, which is the muscle that helps you bend your elbow and turn your hand. And that muscle has a tendon, and it can rupture. And it turns out that patients who have heart failure and have a ruptured biceps tendon have a high chance of having amyloidosis. And this was also found in the patients who had heart failure. So this is an important feature to think about or to recognize in your patient. The other thing that's not so clear is the presence of lumbar spinal stenosis. So spinal stenosis is a low back pain, and very often people with spinal stenosis will kind of, when they walk in the grocery store, they like to lean on the cart because that opens up the spinal canal, stenosis meaning narrowing, of course, and it opens up the spinal canal when you bend over, hunch over, and push a cart. And it's said that the spinal stenosis is a feature of amyloid. Spinal stenosis is such a common condition in the general population, especially as people get older, that it's really hard to use that as a feature. Not like biceps tendon rupture, not like carpal tunnel syndrome. And in this case, at least in the study from Denmark, it wasn't really it didn't really stand out as a symptom. So V30M, just a word about that. Wild type and most of the variants, V122I, T60, and so on and so forth, those patients will get a cardiomyopathy. The V30 patients more likely will get a cardiac arrhythmia. So they have more atrial fibrillation, atrial flutter, rather than enlargement of the heart. Otherwise, there's not a lot of difference between the two groups in general. So these are patients of mine, and I want to just show you that amyloid is a systemic illness. Listed on the right are the features of the disease, the systemic features of the disease. The lady in the middle came in and said to me, Dr. Khella, I think I have amyloid. And I said, why do you say that? And she said, well, I have numb feet. My dad had numb feet. And then I developed this hemorrhage over my eye, and I decided I better come in. And sure enough, she had the T60 variant. The man on the left had what we call macroglossia, or a thickened tongue, and that tongue is due to amyloid deposition. While this is a feature of amyloidosis, it's more commonly seen in people with light chain amyloidosis, or the amyloid related to the malignancy rather than to the hereditary variant. And then this lady had bilateral hematomas. Again, this is light chain amyloidosis. It can be really pretty spectacular. Dr. Gertz gave me that picture. And then Jamie Morell on the left in the bottom of your screen told me about the Resident. So the Resident evidently is a TV show, and they presented this young lady with biceps tendon rupture, and they presented her case as an unknown kind of medical problem. And when Jamie was watching this program, Jamie's a friend of mine, she watching the program, she goes, oh, I think that lady has amyloid. And they show that the biceps tendon rupture, which is you can see down there in the screen. The thing is that biceps tendon rupture tends to be a feature of wild type amyloidosis, which is, as I said, is a disease of older men rather than a young woman like that. But anyway, it makes for a good TV show. This is just a how I make a diagnosis. If you have the genetic test and it's negative, and you have a biopsy that's reliable and it's negative, then you really don't have amyloidosis. If the genetic test is negative and you've got a biopsy that's positive, and you can see down there where it says wild type, that means you have wild type amyloidosis because your genetics doesn't show a genetic change. On the other hand, if your genetics are positive and your biopsy is negative, then you can be considered a carrier and may never develop the disease. You may just have the gene, kind of like I told you with the V122I patients or the T60 patients, or really any patient. And then if the biopsy is positive, then you have hereditary amyloidosis, the disease. And once you do the biopsy, like I said, you need to have the mass spectroscopy or the immunohistochemistry to identify the protein. So I want to just quickly talk about the management of this disease. This is Andrade, who is first described the disease in 1952, and there was no treatment until 1990 when we did liver transplantation for the disease. We don't do liver transplantation anymore because we now have these great therapies that have now had FDA approval, as you can see there. J.J. Kelly was the first to recognize and develop a molecule that looked like it could stabilize TTR. And the reason I have Jamie's picture up there again is because she's the one who designed this timeline, so I like to give her credit for doing that. So there are three mechanisms of lowering TTR. One is the ASO, that's eplontersen, that we now have available. The small interfering RNA is the another way of doing this lowering TTR. And now we have CRISPR that's being tested, and that's a gene editing thing. So this is a way of editing the DNA rather than affecting the RNA. Now it gets into the weeds here a little bit, and I don't want to do that too much. But this is just a way of saying this is a way to reduce TTR that's circulating. And so the targeted therapies right now, as I said, we have the silencers, which are eplontersen, patisiran, and vutrisiran. And then we have the stabilizers that stabilize the tetramer, and that's Tafamidis, acoramidis. And diflunisal is like a Motrin and naproxen. It has been shown, it's a non-steroidal, and it has been shown to affect stability of the TTR. And now there are ongoing trials trying to get rid of the toxic protein out of the tissue. This is still undergoing investigation. So just a quick word, because we're running out of time, and I want to leave some time for questions, about the clinical trials that showed and proved that these drugs work to reduce the progression of amyloid polyneuropathy. So this is a really well-designed science. As the Apollo trial was the patisiran trial. So it was in people aged 18 to 85. A fifth of them were from North America. And as you can see here, very few patients were V122I patients. So the neuropathy impairment score, or NIS, as you can see there in the panel on the left, this is the examination that we do in the office, that neurologists do in the office. And then there's a score from 5 to 130, 5 being clearly nearly normal, and 130 being really having a very bad neuropathy. These patients were taken as a group, and then they were randomly given either patisiran or placebo in a 2-to-1 arm. And this is the result. And this is for somebody who treats amyloidosis. This is spine tingling results. You can see that the patients who got placebo, the neuropathy impairment score just kept getting worse and worse. As I said, the higher the number, the worse. And you can see that over 9 months and 18 months, these people just got worse all the time. Whereas the people who got patisiran, in this graph, it looks like they got better. I don't tell patients that they are going to get better, although some do. I tell patients that they're going to stabilize and not continue to progress. So it not only was the neuropathy measured by the doctor, which is what's on the left, patients were also asked about their quality of life. And people felt better. Their quality of life improved. And that's the treatment on the right. And you can see the panel on the right. So these are statistically significant, unbelievably good results with these drugs. The drugs turned out to be safe. There were some infusion-related reactions, but really no serious adverse reactions. The quality of life at 5 years was maintained. And you can see on the left, as I said, the patients did get a little worse. The bottom line on the left-hand graph, the neuropathy did get a little bit worse at 5 years, but really nothing like the placebo arm, which was going straight up, was getting really dramatically worse until they went into the open label extension. And you can see that in the top line. And the neuropathy then stabilized and stopped from progressing as fast as it had been going. And what you can see, though, however, is the patients who had a worse neuropathy score at 5 years, so compared to the patients who got treated earlier in the trial. So the lesson here is the earlier you treat, the more nerve you will save, the better off people will be. So you got to make the diagnosis as fast as you can possibly do it. The same thing was the Helios trial. So patisiran was an every 3-week infusion. Vutrisiran is an every 3-month infusion. Again, it was compared to patisiran, and then it was compared to the historical placebo, the placebo arm in the Apollo trial. And the reason it was they used a historical placebo and not an actual placebo. They used the group of patients because the group of patients was about the same, and it was felt not to be ethical to give patients placebo for a disease that's progressive and fatal, a placebo when you know you already have a drug that works. So they did that, and they got the same results. Basically, compared to the historical placebo, quality of life and the neuropathy really stabilized dramatically. The baseline and the quality of the baseline neuropathy and the baseline quality of life just shows here in these graphs that these patients did better the earlier they were treated. So the longer you wait to treat somebody, the more you lose, and the patients don't do as well. So again, vutrisiran did as well as patisiran and was equally safe. There were no deaths attributed to the drug itself. Some people died, but not because of the drug. The Neurotransform, which is this trial, that's the name of the trial for eplontersen, again, it was compared to the historical placebo. This is a once a month or every 4 weeks under the skin injection. And again, it was compared to inotersen, which is not being made anymore. And that was inotersen was the original um, uh, medicine that was used like patisiran. It was given as an under the skin injection. But anyway, it was compared to inotersen. Then patients went into the open label extension for 3 years, and the analysis was done at 66 weeks, and then again at 105. And you can see again the differences are like the other drug, just dramatic compared to a placebo, both in terms of how patients felt and how the doctors were seeing the patients. The secondary endpoints were all met. And so a clinical trial has a primary endpoint and then it has some secondary endpoints. And these were all met, including the stabilization of the MBMI, which is the modified body mass index. And that shows that patients' weight stabilized on these medicines. What does not improve a lot in this very busy slide is the diarrhea. And diarrhea for a lot of patients is a really important feature of this illness and the one they care most about, more than the neuropathy, more than the heart failure. You know, the diarrhea prevents people from going out into the street, going out into socializing, going out to a restaurant. And I'll talk about the diarrhea in a second. It does improve to some extent with these medicines, but it doesn't improve well enough. And in the interest of time, I will just skip through here. I already told you how these medicines are given. CRISPR is going to be a one shot where you edit DNA and lower TTR, and it's supposed to be a one and done thing. The trial is ongoing right now. The phase 1 looked like it was safe, and the drug was safe and that it worked. But now we need proof that it really works. And this is the phase 1 trial. There is a dose escalation trial. These are the results showing improvement, and the drug was really quite safe. There was no vitamin A data, but vitamin A drops, and with any of these medicines, you got to take vitamin A. So far, nobody has had a problem with their vision, but you never know over the long term. Just a word about diarrhea, and then I'll stop. Opioid agonists can be used to mitigate the diarrhea, but it does cause constipation. I have recently found that a drug called aprepitant, which is not approved for amyloid, but is approved for people who are getting nausea, vomiting, and diarrhea from chemotherapy, works. And aprepitant, I've liked it a lot. But you need the insurance approval. So you might want to talk to your doctor about that if you're having a lot of diarrhea. So just to summarize, amyloid neuropathy is progressive. Carpal tunnel syndrome may precede it by a couple of years. Look for people who have also heart failure with preserved ejection fraction. Look for dysautonomia. Document the presence of amyloid and treat as early as possible. Thank you. I will stop sharing my screen.
Great. Thank you, Dr. Khella. We just have some questions for you now. Someone had asked about, to help manage their neuropathy, what about physical or occupational therapy? What are your thoughts along that?
Love it. I love occupational and physical therapy. The busier you are, the more you do. Absolutely, especially in amyloid where you have weakness, and the weakness can be improved by that.
Great. And they're also asking if there are any other lifestyle changes that they can make in addition to the medications.
It has to be individualized. I mean, part of the lifestyle is the diarrhea is caused in some people by certain foods. So you have to be sensitive to what foods trigger your diarrhea or constipation for that matter. And you know, you have to sort of work with an OT to mitigate the you know, the parts of your house that need to be rearranged.
Right. Um, and we've had a couple, I'm just looking here, a couple that people are asking about sort of the progression of neuropathy. And I know you talked about that a little bit, just starting with numb toes. And just could you talk a little bit more
Sure.
about that? Yeah.
Yeah, so as I said, unlike diabetic neuropathy or really any other type except CIDP, amyloid neuropathy is a progressive neuropathy. It gets worse and worse and worse without treatment. With treatment, it really does stabilize. And sometimes you can get it reversed. The lady that I presented actually couldn't feel below her knees at all. And after she started the medication, she actually can now feel her skin on the below her knees. So it can be improved. What I didn't talk about is the pain associated with the neuropathy,
That
and
was
that
another
has
question.
certain medications,
Yes.
and you need to talk to your doctor about that. I personally, I like to avoid the narcotics because you can get a lot of pain relief without the narcotics, because then you have to deal with a narcotic addiction in addition to everything else.
Right.
I don't mind using the narcotics, the tincture of opium for the diarrhea because that can be really quite severe. But there are a lot of options for amyloid neuropathy pain.
And if someone's not living near an amyloidosis center, they don't kind of have access to that specialty care. Um, what would be your suggestion for helping people find a neurologist who could help them with neuropathy and understanding what kind of questions do they need to ask when they are trying to find one?
So I would say I have two parts to that question. One is I would get a second opinion for sure from an amyloid center, even if you have to travel far away, because this is a really tricky disease, and not a lot of people in the community, neurologists and so forth, really know a lot about this disease, and it takes a lot of work to maintain your expertise. So I'll get a second opinion at least once. And what we often do is we will work with a local neurologist. So you don't have to be coming all the way to our center or anybody else's center over long distances all the time. And we're happy to collaborate with a neurologist. What I would suggest, though, is to see a neurologist who does EMGs,
Mm,
because that's a neurologist who really has an interest in neuromuscular disease and peripheral neuropathy. And I would work with somebody like that, or somebody who has somebody like that in their practice, who has EMG in their practice.
right. Um, Someone was, and I know you'd mentioned talked about the diarrhea, but are there any other drugs or treatments that you would again kind of
Sure.
just, yeah,
Yeah, the aprepitant, like I said, has been a godsend for some patients. Tincture of opium is problematic because it can all of these drugs can cause constipation,
mm,
and the constipation can then become really problematic. And so you kind of have to juggle it a little bit. It does require a lifestyle change. It does require change in diet, and you have to
okay,
figure out like what are the foods that trigger it for you.
okay. And this person is asking, what are the odds that someone with wild type will develop neuropathy?
So that's a great question. Wild type is a disease of old men, unfortunately. And old men get a neuropathy anyway. So people over the age of, not just old men, but anybody over the age of 60, about 10% of them will get a neuropathy. And that number actually increases as you get older. So it gets a little harder. There has been no documented cases of where somebody's taken a nerve, looked at it under the microscope and said, aha, this patient has wild type amyloidosis and has wild type neuropathy because I see the amyloid in the nerve. It's never been done. So what we normally people who get a neuropathy in who have wild type, it's usually the pain associated with the neuropathy, and we just treat that.
And treat that. Okay, great. Thank you. We'll look for a few more questions here. Asking, does tafamidis ever improve neuropathy?
So yes, tafamidis is not approved in the United States, but in the clinical trial, it was shown to be effective in early stage peripheral neuropathy in stage 1, and it is approved in Europe for stage 1 neuropathy. Stage 1 is where you have no disability from the neuropathy. You can walk without a cane or a wheelchair or anything. So it is approved. So it does work. It doesn't work as well, I don't think, as well as the silencers, but yes. And for that matter, diflunisal works. And I put some carriers on that as well, if they're really anxious and want to be treated with something. And Dolobit, which is diflunisal, you can get by prescription.
Great. So we have a couple of different questions where people have other types of, somebody has lupus and hereditary, and also someone that, is just asking, they're having neuropathy, but could it be the lupus? Could it be somebody else had talked about having varicose veins? These different things to kind of be able to tell what might be related to amyloidosis and what might be related to something else.
Great question. And this is what we struggle with all the time. And that's why it's good to get an opinion from an amyloid neurologist who specializes in amyloidosis, because that's what they think about all the time. It's like, is this patient's neuropathy from amyloid or is this from something else? And you don't want to be treating the wrong thing. So absolutely. And you need to really see somebody who can make the distinction. But like I said, the main feature of amyloid neuropathy, it gets worse, and it gets worse quickly over a year or a couple of years.
Great. Okay. Well, I think we are close to our time today, so we appreciate your joining us. Know that you are probably in clinic today and seeing patients, so we certainly appreciate that you took the time to join us today. And we are thankful for all of you who joined us today as well. And just a reminder that we will see you again in October. Our next webinar is going to be in honor of Caregiver Appreciation Month. So we will be having a webinar specifically for caregivers on tips for thriving and surviving as a care partner. So we look forward to seeing you again. And again, this was recorded and will be available on our website. So thanks again, Dr. Khella. We appreciate you joining us, and have a good afternoon, everyone.
Thank you all. Goodbye, everybody.
Thanks.